recording. Okay. So what we're going to show now is parts of a shoulder assessment. So we would ordinarily start with the postural assessment. I'd just like to highlight one or two things that you should be looking for before you even begin checking the shoulder complex. So when we look at the upper part of the body, we would be looking for angles of protraction, whether the shoulders are rounded or whether the scapulae are adducted and they're in a retracted position. Obviously, any indications of kyphosis or flat back in the thoracic region. Check the lordosis in the cervical region and whether the client is protracted, and all of these will obviously have a strong influence on tight muscles, long muscles and so on. Once we've checked all of the posture, we will move into active movements, and obviously we would do passive and resisted as well. For the purpose of this demonstration, we'll show the active movements and we'll show just some of the resisted movements that are particularly important when checking rotator cuff. So if we start with active movements, Jade, can you show us arm flexion first of all? Just taking arms up and back down and into extension. Thank you. Then if you can show us abduction. And back down and comfortably across into adduction. Good. If you can show us from standing position internal rotation with your elbow flexed. So from there, thank you. And obviously there's the extremes of internal rotation, putting the arm behind the back. And external rotation. Thank you. We can also include movements of horizontal adduction and abduction, so bringing the client's arms out to a horizontal position. There's horizontal adduction and horizontal abduction. Okay, if we separate out the shoulder complex movements, these are movements particularly of the shoulder girdle. We would look at elevation, so raising the shoulders, taking them back down, which is depression. And then rounded shoulders, as we like to call it, protraction. And then the opposite, retraction. Some other tests that we would do at this stage, Apley's scratch test. Jade, if you could just turn around, please. Two types of tests to check for general mobility, which also test the integrity of all of the rotator cuff muscles. So the first one is to ask your client to flex the arm at the shoulder, so bringing the arm forward like so, and to reach over behind your head and just down the middle of your back. Make sure your client can do this comfortably, and we can see general mobility for Jade on her left arm, and we would then compare the same with her right arm. So if you could just show us how far you can go with the right, and you can see a clear difference there between right and left arm. The other lower Apley's scratch test we need to be careful of. We ask the client this time to take the one arm behind the back, but to reach up and across towards the opposite shoulder blade or scapula. It's important to be clear with your instructions here. Some people will have the mobility to put the hand right up the middle of the back. That's okay if they've got the flexibility there, but if they're already suffering from a shoulder condition, this can put a lot of strain through the actual capsule itself. So the last thing we would want is for somebody to actually cause further trauma to the tissue actually doing this test. And again, if you can show us your right arm, please. And again, we can compare and see that there's a lot more tightness around Jade's right shoulder than her left shoulder. Other things that we would look for in doing the shoulder abduction, we would check for the general mobility and the scapulothoracic movement patterns. So what should happen, you can see clearly here the shape of Jade's scapulae on each side with the inferior angles there. the inferior angles, we can see they will rotate laterally to facilitate arm abduction. And what we just observe is that there is a smooth movement pattern there that is equal on both sides as she abducts her arms. So we can just watch for those, and we can see a reasonable movement pattern, slight differences from one side to the other, which we would analyse further and try and ascertain where the alterations in movement patterns are occurring. Okay, if you'd like to now turn back around. Some other tests that we would do with the person standing. First of all, what we call the painful arc test. So once again, we're going back to that action of abduction, and we can do this one arm at a time. And this would be looking for indications of any form of bursa impingement type syndromes. And the painful arc basically means that as they abduct the arm, they will get to a position that is uncomfortable, and then significantly that pain will subside again once they get to a further angle. So any pain on that side? No. So if we now show the right arm, when they get to about 70 degrees, this angle here, what's happened is the greater tubercle of the humerus has now reached a point where it's starting to travel underneath the acromion process. The gap will have significantly narrowed, and so if there's any impingement or inflammation of the tissue there, particularly the bursa, at this point it will start to be compressed further. So your client will typically report pain from about 70 degrees, it will continue, it will get worse, until one gets to about 120 degrees, this sort of angle, and from this point the bursa will now have passed underneath the acromion process, and so the pressure will be alleviated. So rather strangely, instead of the pain increasing, from here it will decrease again, and then as they come back down they'll get to 120 degrees, painful again, back to 70, and the pain will subside. So that's one of your indications for a subacromial bursitis problem. If you have that problem, one further way that you can test for this is to passively extend your client's arm whilst palpating over the superior aspect of the shoulder. So from here you can feel the acromion process up here. If we just rest the fingertips anteriorly from that position, draw the arm back into extension, what I'm now doing is drawing the head of the humerus forward, and with it that subacromial bursa. So if we get to an extended position, I can now put pressure on that subacromial bursa, and again, if that causes pain, we have another indication of a bursitis problem. Whilst the client is standing in this position, we can also do further tests. We can check for supraspinatus weakness and any indications of trauma to this muscle. And for this, we know that supraspinatus, sitting in the supraspinatus fossa on the top of the scapula, tracking through and underneath the acromion process and inserting on the lateral superior aspect of the head of the humerus. When it contracts, it initiates the first bit of abduction of the upper arm. So it has to work before the deltoids can take over and continue with abduction. So those first 15 degrees are particularly significant, and therefore I would just add a little bit of resistance and ask Jay to gently push against me, and if there's weakness there or pain felt, then that's an indication that supraspinatus has been affected. Typically what you'll see with the client, if they're trying to do an active movement of abduction, is that they'll kind of try and throw the arm out to get past that first 15 degrees. You may see them side flex in that fashion just to try and comfortably get past that. Once that happens, deltoids take over and complete the movement. So they're the sort of visual things that you would be looking for at that point. If you suspect that supraspinatus has been damaged, you can do what we call the empty can test, and for that we get our client to take the arm out in front like so, and imagine that they're holding a can and just emptying that onto the floor by pronating the forearm. That movement, if supraspinatus has been damaged, is likely to be uncomfortable. If you think that it's a mild strain to supraspinatus, from that position, once they're fully pronated, one can ask them to just push up in that fashion against some resistance, and that will certainly elicit more pain if it's been damaged. I wasn't on there.